All right. And are we going to start the webinar with the sheets with the screen already shared, or are we
Is that fine, Dr. Joseph?
I'm sorry, will you be, do you have slides of your own? Do you want me to stop sharing?
No, we do not. I just want, are you fine with this being, you know, up while we introduce you?
Yeah. Okay, I can move you guys to the side. That's fine. That's good.
All right. Once the clock hits 3, I will begin the webinar.
All right.
There we go. Okay. 3, 2, 1.
All right. You can see people popping in right now.
And Laura, you'll do the introduction first. And
yep, I will introduce you once it looks like we have all the attendees popping in. You can see the numbers kind of going up right now. So when it looks like we have everyone, I'll get us started.
Oh, that's great. We have over 40.
Great, just keeps going up.
Keep going up, yeah.
Yeah, almost to 50 now.
most of them interior design students.
Let's see. It looks like mostly right now. Yep, interior design students.
And I know we are going to have also faculty joining from planning, urban and regional planning, and landscape architecture. I've seen some talking about the presentation earlier today. And there are other interior design faculty who are in the room as well, but not as panelists, so I can see their names.
That's awesome.
Yeah, awesome.
All right.
Okay.
I think we're probably ready to get started. If people are joining us, that's okay if they join a few minutes late. Okay. Wesley, will you have the participant list for us after?
Yes, I will.
Okay, awesome. Okay, let's get started. All right. Okay, hello everyone and welcome. We are so excited to have Dr. Anjali Joseph here with us today to speak on improving safety and quality through evidence-based healthcare design. Dr. Joseph is a professor of architecture and industrial engineering, Spartanburg Regional Health System Endowed Chair in Architecture and Health Design, and director of the Center for Health Facilities Design and Testing at Clemson University. Dr. Joseph teaches in the graduate program in architecture and health at Clemson, where she trains architecture students in designing healthcare environments to support patient, staff, and organizational outcomes. Dr. Joseph's research focuses on multidisciplinary systems approaches to improving patient safety and quality in high-stress healthcare settings through the development of tools and built environment solutions. She has served as principal investigator on multiple grant-funded projects from the Agency for Healthcare Research and Quality, the Kresge Foundation, the California Healthcare Foundation, and the U.S. Green Building Council. She currently serves as PI on a multi-year patient safety learning lab funded by AHRQ, focused on designing safer and more ergonomic operating rooms. Dr. Joseph's work has been published in many peer-reviewed journals, and she has spoken widely to national and international audiences. She was also recognized as Researcher of the Year in 2018 by the Healthcare Design magazine. We're so excited to have you here with us today, Dr. Joseph. For everyone attending, if you have questions, please pop them in the Q&A. There'll be a few points throughout where we'll address the questions, and then we'll have more time at the end. And with that, I will let you take over.
Thank you, Laura, and also thank you, Linda and Dr. Lee, for inviting me to be on this panel. I'm so excited to speak with all the wonderful students and faculty at Michigan State University. As I'm going to show in a little bit, I have one of the students from your program who is working with me right now, and I love that I'm able to connect with her peers and talk to them a little bit about what I do and hopefully inspire them to maybe come work with me someday. But I'm going to give a little bit of an overview about the Architecture and Health program here at Clemson and the Center for Health Facilities Design and Testing. Then I'm going to talk really about my passion about designing safer and better quality healthcare facilities and health systems, and go a little bit into the research on built environment and patient safety and evidence-based design, and give you some examples from a couple of studies that I've been working on over the last several years, so you get a sense of what we do and how that connects to design and some of the work you might be interested in. So Clemson's Architecture and Health program is, we're based in Clemson, South Carolina, and it's 54 years in existence as of now. And over the years, it has grown, and we have about 16 students in our program at any given time, about 8 a year. And our students go on to do really great things, work across the US and internationally. We have had 277 alumni so far. Our students work in the US, but they also have a pretty large global footprint, and they impact healthcare. And they usually end up working with different kinds of healthcare facilities and even healthcare organizations, and bringing about change in how buildings are built. The kind of projects they do varies in scale from anything at the campus level to the building scale, of course, and of course also the detailed room level, such as operating rooms that you're going to hear about. So within all of that is the Center for Health Facilities Design and Testing. And I think one of the unique things about our program is that the professional practice aspect of the program and the research component are very strongly linked. Both spatially, we share a space as well as we do research together. The work they do is informed by design, and some of the priorities for our research come from an understanding of what's needed for design and by designers. So the research is embedded in practice, and so is the practice embedded in evidence and research. And this is how we think, this is one of the key strengths of our program. So this is just a picture that shows you our space. And the Architecture and Health program has 4 key faculty and a research assistant professor. And all of these people are very well established in the field, and they all love what they do. And this is our team, the Center for Health Facilities Design and Testing. And there's Sarah Kennedy, who's one of your graduates, who's just amazing. And she's such a great person to have in my team. I enjoy having her in my office every single day. But we have a very diverse team, people from all over the world who come and learn, and then they take this forward with them. So what do we do here? Most of our work, one of the key things I think that that is our focus is that most of the topics that we're interested in, we do in-depth research about it. Then eventually that should lead to design in most of our projects. And then that should lead into some sort of a built project. We might prototype it or build it in virtual reality so we can understand if the design concept works, and then that gets fed back into the research. So that's one of the, I would say, the DNA of our program is this real strong focus on prototyping and testing. And we feel that that's a very important way to take research into the field in a quicker way, in a more credible way, and such that it can make an impact on designers. We often focus on those aspects of the healthcare settings that are repeated very frequently and where significant patient care is delivered. So it could be things like a patient room or an exam room or an operating room. This is where the interface is the strongest between the patient and the care providers and the environment. And these are built many times. You'll have 100 patient rooms or 28 ORs. So it's very important to get it right. So we feel it's important to focus on those kind of settings. And that is really the interior design scale that you all work with. So that's the connection is very strong here. And our research agenda is pretty broad, but we look at issues of patient safety, patient and staff experience, as well as population health. So these are some of the broader topics that I, as well as my students, are interested in at the center. How does design impact operational efficiency and effectiveness? How can we do more and better with fewer resources? This has become extremely important now in the context of COVID. Staff are leaving the profession and the pressures are much higher. How can design support what they do? How can design impact therapeutic outcomes? How can it help in improving patient and staff safety? How can design improve the experience for the patients, for the family and the staff? Again, all of these questions are becoming even more important and relevant in the context of COVID, because not only are the patients and families stressed out, but the staff is trying to do so much in very difficult circumstances. And then how can facilities be designed to accommodate changing needs over time? This is a huge, huge problem in healthcare because facilities are built and then everything else changes. The clinical care models change, the technology changes, but the buildings are often not flexible enough to accommodate all of these changes. And then this is a particular thing that I'm very passionate about. How can design promote healthy lifestyle and population health? My background before I came to Clemson, and actually my PhD dissertation was on how do you design retirement communities to promote walking among older adults. So, anything from the campus scale to the building scale is of importance. And I think one of the things I didn't mention is my background is an architect. I'm trained as an architect, and I have a master's in architecture from Kansas State University. And all of that got me thinking about the human being at the center of it all, and how does our design impact humans, which is why I ended up doing a PhD, and here I am. So going a little bit into healthcare design and what do we mean by these challenges, and why does design make a difference? Of course, here I'm speaking to the choir, but when you guys go into practice and you're talking to, say, office workers, or if you're talking to healthcare clinicians, they often don't get what we're trying to say, that your design matters or the physical environment matters. They think that patient care is really about the care they provide to the patients, and often it takes them a little while before they understand, yes, the building can make a difference, and it's one of the many things that does make a difference. I'm sure many of you have heard this, or if you haven't, you will hear it many times during your career. We shape our buildings, and afterwards our buildings shape us. So this was actually spoken by Winston Churchill in the context of the redesign of the Commons chamber that was destroyed in the Blitz during the Second World War. And there was a big discussion about how this new Chamber of Commons should be built. And he was insistent that we should keep the rectangular shape, which was important for maintaining the two-party democratic system that we know is a symbol or landmark for the British government. And his thought, that's how it kind of came to be, but it's been appropriated by architects everywhere, and we love it. We like talking about how that explains how design works. But then there is this other saying, which is also similar, but Dr. Paul Batalden says every system is perfectly designed to achieve the results it gets. So a well-designed system is going to get good results, but a poorly designed system will result in all kinds of problems. And we'll talk a little bit about that as we go along. And then leading from that into sort of the built environment and design. And I was talking to Sarah, and she mentioned that you guys know what evidence-based design is. So she gave me a little bit of background, and but just to kind of reiterate that, evidence-based design is the process of basing decisions about the built environment on credible research to achieve the best possible outcomes. And so just to kind of tease it apart a little bit, some of the key things are it's based on evidence. That means we're making design decisions, but we're not making it based entirely on intuition or past work, but we're also trying to bring in the best knowledge that's out there. And it could be knowledge from case studies, it could be knowledge from published research, but bringing that in order to make decisions. And I think another key thing about evidence-based design is that it begins to bridge what we know as designers with what matters to our clients. In my case, the work we do, our clients are our healthcare facilities. So what outcomes matter to them? So if we go in as architects and say, yes, we think you should design a building which has the best views of nature, I mean, they will get it. It makes common sense. But if you can provide the evidence that links it to their outcomes, that this will help in reducing pain, perception of pain, or it'll help in reducing the length of stay. Now you're talking their language, right? You're talking about the things that matter to them. So I see evidence-based design as a bridge between what we do as designers and what matters in terms of healthcare outcomes that our clients care about. So it's about language, and it's about making those connections and speaking, sort of helping them understand how our work makes a difference. So I just wanted to give you a context of one of the most seminal studies in our field. Again, if you end up working in healthcare, you will hear about this many, many times. But Roger Ulrich, until recently, was a professor at Texas A&M, and he did this work in 1984, where he looked at data from like retrospective data over many, many years. He was looking at patients who are recovering from gallbladder surgery. And some of these patients had windows, were in rooms with windows facing nature. And some of them looked onto a brick wall. And interestingly, What he found was that the patients with rooms with to nature recovered faster, they used less pain medication, and they were more satisfied with the care they were given. So that was pretty astounding and in many ways important information for our clinicians as well as for the architects to say, yes, we're not just designing buildings that are going to stand here forever, but those buildings can make a difference and they can actually help in solving some of the problems that our clinicians and our patients face. So it began to speak that language that I was talking about. So that continues to be sort of this focus, even though, you know, our study helped to highlight a very important element about the fact that the buildings can make a difference, can impact outcomes. As time has gone on, and as we understand really well, it's not a simple thing. You know, just designing a building is not going to change all our problems. It's not going to solve all the problems that we have in healthcare. It's just one part of a very complex system, right? Obviously, the care provided, the policies that are in place, the technology that they're using, all of these things matter as well. And they usually interact with the built environment to make a difference. So the challenge that we have in healthcare is how do we study these complex systems? It's not just one thing. It's not just the built environment. It's not just the people. How do we study these? And then how do we make sense of from this research to inform design decision making? So is research so far away from design that as a designer, I have no idea what to do with this research you're doing? So that's another challenge that we're always striving to address. How can we translate this research into ways that make sense to designers? And then how can that design support dynamic changes to the system? And again, humans are at the center of it all. So all the decisions that we make, all the designs that we work on should be linked to what needs humans have and then address the changes over time. At this point, I don't know if you have any questions. It's kind of early. I see a couple of things in the chat. Does it make sense to address questions or keep going?
Your question.
I don't know if there are questions or.
So we have one question so far. It's a little bit more broad, so that might be a good one to wait till the end.
Okay, sounds good. All right. So I'm going to talk a little bit about built environment and patient safety. As I mentioned, that's my passion. And one of the core principles in medicine is first to do no harm, right? So our buildings, our care at the first and foremost should be helping people heal and get better, and it should not cause any harm. But unfortunately, what happens very frequently in healthcare, and the numbers are quite astounding. I don't have the videos here, but there is a lot of harm that's caused to people while they are in healthcare settings. The number of infections, I think it's like every year there are about 100,000 infections or maybe larger. And the same thing with the number of falls that happen. And these are called adverse events and in healthcare. So basically when you come into a healthcare setting, you're coming in to get better. But there are situations in which something bad may happen to you and result in harm to you. And those are the ones that we have to avoid. So one of the key goals in healthcare is to try and avoid these adverse events that happen. And when these bad things happen, often what happens is that the clinicians who are responsible for providing care are blamed because they were at the sharp end. That's where the failure happens. You know, the wrong medicine was given, or a patient fell in the hospital room, or someone came in and acquired an infection that they didn't have when they came into the hospital. So you end up blaming the hospital system. But what we've learned over the years is that it is not just what happens there, because what happens with an error that happens at the sharp end is often due to human condition. You know, you can't really change that. But there are a lot of other elements in the system that contribute to those active failures. And we have many layers in place to prevent those bad things from happening. So, you know, the training for teams and individuals, doctors go through years and years of training for that. There are clinical guidelines and policies, organization culture, equipment and technology, the built environment, all are designed to provide the best possible care. But what this Swiss cheese model shows is that it's really, all these layers are like layers of a Swiss cheese, and each of these has many holes in it. just because there are problems in how they were designed. And sometimes, and most of these holes are, latent. They just sit there. They don't really make a difference. But sometimes all of these holes align and a really bad thing can happen. And so it's important for us to figure out how can you design all of these layers to minimize these holes so that we can have a better design. And this is like translating it more into the design of the built environment. And I talked about the system. If you think about the human being at the center of all of this, and the human being will interact with teams, with cultures, with processes, and then the physical environment itself, how does it impact these bad things from happening? So, for example, poor sight lines from the nurse's station to the patient room might exacerbate a condition where a patient gets up to go to the bathroom, they fall, you don't find them. So that could be a factor that impacts poor outcomes. Or it can create conditions where the environment is very tiring, it's noisy, it's challenging, results in fatigue and stress and annoyance, and then that leads to a bad thing happening. So this is just a way to conceptualize how the built environment fits into this complex system I was talking about. So I wanted to give you a couple of examples because this is all abstract so far. And these are some key types of safety outcomes that are common in healthcare settings where the built environment can actually make a difference. But I'm going to talk about just a couple of these: patient falls and hospital-acquired infections. Medication errors are also common. These are wrong medications given during anesthesia or in the patient room. Psychiatric injuries, behavioral health. This is if you're in a patient with mental health condition and injuries occur due to violence or self-harm or so on. Musculoskeletal injuries are also very common with nurses and other clinicians when they're lifting heavy patients or moving things or reaching for things because the design is not supporting their work. And needle stick injuries, like staff accidentally harming themselves from sharp needle sticks. But I'm going to talk about falls and infections here. So patient fall is defined as an unplanned descent to the floor with or without injury to the patient. And surprisingly, 700,000 to 1 million people fall in US hospitals. So this happens very commonly. And it's a very complex problem. Almost all hospitals have falls prevention committees, and they spend a lot of time and effort to try and reduce falls. And it's a complex problem, needs multiple solutions. But the thing is, what they found is 1/3 of these falls are preventable. And what has become even more challenging is that as of 2008, the Centers for Medicare Services that provides reimbursement to hospitals for Medicare and Medicaid patients, they have put in a policy where hospitals will not be reimbursed for traumatic injuries that occur because of a fall. So for many, many reasons, falls are these are just the financial reason and the numbers, but of course there's a lot of emotional and other impacts on the patient and their families. If you fall while in the hospital, you're going to stay longer, as many as 6.3 days longer in the hospital, and then your recovery is going to be harder. And especially many of the people who are in the hospitals are elderly, and for them a fall can be harmful in the long term and may have impact on their mortality. But most falls occur when patients try to get to the bathroom. Why do they happen, right? Fall reduction strategies are multifaceted. So as I mentioned, it's not a simple thing of just fixing the built environment and it'll all go away. It has many, many elements to it. So you have to be able to identify the patients who are at high risk of falls, what kind of medications are they being given, what are the nursing ratios. There are many, many things that need to be taken into consideration. But from the design perspective, some of the things we found are if you can provide family zones in rooms, then it's likely that family may be present in the room. So they may be able to help a patient who's getting up, removing barriers and obstacles for movement, providing low-level lights, providing handrails and supports, providing decentralized nurses stations, and sight lines into patient rooms. And I'll give you guys a couple of examples. So this is the Dublin Methodist Hospital. I was involved with some of their evidence-based design research work because they were a Pebble project while I was at the Center for Health Design. And they had this unique opportunity to design this greenfield hospital. So completely from scratch, hire completely new staff and come up with the most exciting and new ideas. So one of the things that story apart. They did a lot of innovations and they were really cognizant about the research and they wanted to implement that. So they were trying to figure out how to reduce this problem of falls in patient rooms. So they came up with a solution where they said, okay, people fall when they get up from their bed and go to the bathroom. So what if we provide larger bathroom doors and we can help them so that they have an assisted path all the way from the bed to the bathroom. So they provided a handrail. It's a different matter that this particular image has the bedside table, which would be a real problem if you were trying to get out. But that's the image I'm working with. That apart, I mean, the idea is good. But still, the jury is a little bit out on whether the bathroom should be on the same side of the bed as the head of the patient or across the bed. So they have to walk across the hallway. We don't really know. We need more research on this topic. Then I mentioned decentralized nurses station. So typically hospitals usually had a centralized nurses station where all the nurses work together and they are usually assigned to a set number of patients that they are responsible for. But there has been a move in the last several years to have the nurses closer to the patient so that if, for example, in an ICU unit, in intensive care units, the ratio is usually 2 patients to 1 staff member. So the idea is if you bring the staff member closer to the patient, then they can keep an eye on them and there'll be fewer accidents happening. And it is true, like in this particular hospital, they did manage to reduce falls by 80% by bringing the staff closer to the patients and also providing decentralized nurses station. So that was a very successful strategy. But it hasn't been effectively implemented elsewhere in some of these cases, the curated adaptable rooms and some of these concepts, because there are also staffing issues with that. Staff have some challenges with being decentralized and being in this space because like anybody else, they like being with their colleagues. They learn from each other. If you're the new nurse getting into practice, you learn so much by being around other nurses. So there are no simple challenges, simple solutions to all of these things. So how can you provide them that teamwork and that communication and connection with others while still also providing the safety to the patients? So sometimes there are these challenges that need to be addressed. Then infections, we've all been living through this for the last 2 years. It's hard to believe, right? 2 years we've been doing this, but infections have become part of our life. But healthcare associated infections have been endemic in hospitals for whenever you can, since the beginning of hospitals, right? Even if you go back to Florence Nightingale, even before that, while your goal is to heal patients, your goal is to also make sure that the infectious patient is not communicating infection to others who may have other problems, but they're not infected. So it's a problem. 1 in 25 hospital patients has at least one healthcare associated infection. So these are not infections that you came with, but an infection you acquired while you were in the hospital. And there were an estimated 722,000 HAIs in US hospitals in 2011. So those numbers probably need to be updated, but these have been big problems, as a result of which a lot of focus has been provided by the government, by different organizations, and there has been some improvement. The last couple of years have probably thrown all of this for a huge loop, and I'm guessing the infection rates and patient-to-patient infection, patient-to-staff infection, they were already, I'm pretty sure they've all gone up, but I don't know the numbers yet and where we stand on that. And the hard thing is that patients who are hospitalized with HAIs often die during hospitalization. And many of these occur outside the intensive care unit. So infections are a problem in healthcare, and it is well recognized that the built environment is a factor that impacts infections. So how do infections get transmitted in hospitals? I have a really fun video that shows it, but I'm not going to subject you guys to that over here, but my students have to watch it and they'll be cringing at the end of it. But airborne infections, COVID, we know how that happens, right? You cough, you sneeze, it gets transmitted through the air. But there's waterborne infections as well. Less common, but they still happen. Sometimes you have an infected, you have like a faucet or a shower head which harbors Legionella, and then that spreads it. And for most people, we're exposed to Legionella all the time. But if your immune system is strong enough, you're probably going to be okay. Many of these infectious pathogens are common in our environments. and we have the immune system to deal with it. But if you're a sick patient who's immunocompromised and you're exposed to these infections, it can be really harmful. And then contact transmission. And even though we all know about airborne infections and we know how quickly Omicron spreads, but the major source of transmission of infections in hospitals is actually contact transmission. So from the doctor touching a sick patient and then possibly not washing hands between patients and then touching something else, and that surface getting contaminated, that is really the primary mode of transmission. Pandemic barred, in most situations, that is really how it happens. This is, I can't say I love this graphic, but it does kind of point out some of the key problems. This is the patient in the next bed is highly infectious. Thank God for these curtains. I think the curtains are really the worst things you can have in these hospitals. And that's a great challenge for you interior designers. How can we provide privacy for patients without using curtains? Or what kind of curtains should we have that can be cleaned? I don't know if there's a solution to that. Like other than unhooking them and cleaning them, even if it's got antimicrobial finishes or whatever, I feel like this is a tough challenge to deal with. And of course, in this particular case, there are two patients in the room and you have the curtain in between. The doctor looks at this patient, touches the curtains and goes to the next patient. This is clearly a big problem waiting to happen. So how do you deal with this problem, right, of infection spread? As I mentioned, one of the major problems is the clinician's hands, right? Washing hands is a big problem. And you would expect, right, hand hygiene compliance should be easy, but think about COVID. How often do you sanitize your hands? How often do you wash your hands between all the different things you need to do? And then think about clinicians and the crazy schedules they have and the number of patients that are demanding their time. They probably have to wash their hands every few minutes, right? To be really there, but you have chapped hands and you just are busy and you don't get to it. So it's not that they don't want to do the right thing. Sometimes it's just really hard. So this is a great example that I like to show. Where's the sink? Behind the door to the room. So I enter the room and I go straight to my patient because that's who's demanding my time. The sink is out of sight, it's out of mind. But then I like this example as a contrast in some ways. This is again Dublin Methodist, and what they did was you enter the patient room. There's a little line on the floor that leads you straight to the sink. There's a light shining on the sink, and there's this beautiful glass wall behind the faucet that highlights the whole thing. So hand washing is being celebrated, right? So they were very serious about it, and I wonder what the interior designers think about it. But they were trying to say, okay, you know what? Make it so easy for people to wash their hands and do the right thing so that they will do it. If you make it hard for them, you're adding another level of cognitive burden on people who have so much to do anyway. And their hand hygiene increased. The number of staff that wash their hands before the exam increased significantly, and the infections reduced. But again, this was many years ago. I don't know what happens after you get used to a facility and you've been visiting, you've been living there, working there for many years. Do you forget about the beautiful hand washing sink, or does it continue to make an impact on you even afterwards? A great research study for someone. Another design element that has been shown to make a difference is single patient rooms. As I mentioned, how to design infection spread from the hands of clinicians, from surfaces that are contaminated. And if you have two patients in the room, then it becomes really hard to clean rooms between patients. One patient gets discharged. It's not likely that you can completely disinfect everything. So there is another patient in the room. So that might be something. You can have better cleaning, better air quality, and increase hand washing compliance because they're less distracted by other patients, other family members, and the chances, many studies have shown that single patient rooms help to reduce infections. So that was really a very quick introduction to patient safety and some of the different kind of outcomes. I was going to jump into a couple of studies to give you examples of the work that we've done in the center, but I'm happy to take any questions either from the panel or from the students at this point.
Yeah, we've had a few really good ones that have popped through, so we can address a few of them now. So let's see. Do you think that there's a higher demand for healthcare designers since COVID-19?
I think so, absolutely. I think focus on health, whether you call yourself a healthcare designer or just a designer who focuses on health, is become intrinsic, whether it's the design of public spaces or workspaces, or people who design healthcare facilities. I think for people who understand the role of health in design is going to be an intrinsic part of any design profession. So whether you go into healthcare facility design or any kind of environment, that focus is going to be important, I think. And healthcare facility planners are doing really well. I mean, I think there was a time when things were quiet, but all the hospitals are now beginning to think about, okay, what's the future going to hold? What do we need to do? What happens in a new pandemic? I think the role of design and the role of designers in promoting health is more important than ever before.
Had a few more. Do you think the solutions that are used in healthcare design can translate to commercial or hospitality design? If so, how?
It's a really great question. And I know that's something that was being discussed quite a bit, especially during the early stages of the pandemic when we were disinfecting everything, right? Like we now I don't think we're doing as much of the disinfection stuff. And I remember people telling me that, they're using these industrial grade cleaners on couches, on chairs, on everything in workplace environments, and everything is deteriorating, and they're like, why is it not working? Why is it not holding up? So I think there are different solutions that are needed for these different environments. We have a better understanding of some of those things, but I think the concepts of designing a healthy, healing environment are easily translatable to any other environment. In fact, we've learned a lot of things by studying office environments and how people work in those environments. And similarly, what we're learning in healthcare about access to nature, access to views, I think that's very translatable to home environments or office environments, because the whole idea is to provide a healing environment, to reduce your stress. And as part of COVID, mental health has become a big issue as well, right? And so whatever you can do to improve the experience for individuals is translatable to all kinds of environments, I think, whether it's infection control or patient experience and so on.
Absolutely. Thank you. And then a personal question. What made you want to become a specialist in healthcare?
That's a great question. I guess I didn't introduce that part of it. I love this field, but before, how did I get into it? So as I said, I did my bachelor's in architecture, and I had a typical architecture training where we did lots of studios, we did all that stuff, but we never talked about human-centered design or how humans feel in this environment. And I always felt there was something missing, though I didn't know what was missing. But I was lucky enough to do my master's of architecture at Kansas State University, where they had a specialized program in environment and behavior. And that is where everything clicked for me. Yes, human beings work in this environment, and the environment influences what we do. And I was exposed to various faculty, and especially one particular faculty member who did a lot of work in healing environments. And that made so much of an impact on me that I felt like this is where I could devote my life to, because I felt design and architecture makes a difference, but it makes the most difference in where populations are vulnerable. And, when you have a sense of like, okay, I can make a difference. And I think that's all what anybody wants to do, right? Do a job that satisfies you and you can make a difference. So healthcare is one of those settings. So I was initially focused on long-term care environments and aging. And then that eventually morphed into work in hospitals and healthcare environments. And as I've gotten to learn more about these environments, I also like that they are very intellectually challenging to design, that the problems are so complex that it's hard for any one type of specialist to do anything. So as a healthcare designer or a researcher in this field, you have to work with clinicians, you have to work with engineers. And that is also very exciting to me, because you learn how to speak all these different languages, and you learn how to kind of work across different disciplines. So I think it's just on many, many fronts, this is a very inspiring and fun area to work in, really. Though it's not as sexy when you're in architecture school, but I realized it's really, where the problems are many, and there are many, many things you can do, and the satisfaction you get from solving those problems is huge, because you feel you made a difference. It's a very long-winded answer. Sorry, Laura.
It's wonderful. No, we appreciate it. And actually, another question popped through that I think relates a little bit to what you were just mentioning. But do you apply your expertise in healthcare design to assisted living or memory care facilities? Have you worked or do you work on many assisted living facility projects?
I haven't since my PhD days because I ended up working in at the Center for Health Design and then at Clemson. But actually, take it back. When I was at the Center for Health Design, we did do some literature reviews. I have done some work on long-term care and assisted living. I think there's so much similarity. In fact, in the architecture and health program, we don't exclusively focus on on hospital design. Many of the projects that the students undertake are often in memory care, in long-term care, assisted living. I think the principles translate very easily. There are many similarities. The populations are often similar. In fact, now, as I mentioned, the greatest demographic in hospitals is usually a geriatric population. So we have to be thinking about how do you design hospitals that are aging friendly, not just patient friendly, because many of the population is older as well. So the concepts translate in both directions. And the same, you have therapeutic goals on improving safety and improving orientation, improving quality of life. So I think there are many similarities. The main difference, I think, is long-term care environments often are places where people live. So this is their home, versus hospitals are hopefully in many cases short-term places where you go to get better and you leave. So you have additional constraints and things to think about when you're thinking about assisted living, because you are designing a place for living. So you have to provide a home in many ways, and that provides an additional sort of dimension to all of this. But I find that a training in long-term care or assisted living translates well into healthcare facility design. And if you have experience in healthcare facility design, of course, they all have their own unique elements, but there is a lot of synergy between these two different kind of areas.
Thank you. We have more questions popping in, but I feel like that's a pretty good breaking point. So you can move on with your case studies.
Laura, we can take this one question because it's also related,
which one?
From Elizabeth Rowland. She was researching what you do, Dr. Joseph, and who you are before the lecture, and she saw that you're an independent review panel for military medical construction standards. Is the evidence-based design utilized in the military medical centers as well?
That's a great question. I was actually part of a review panel that went in to evaluate how the military health system was doing with their construction program. Because years ago, they had committed to doing evidence-based design very actively, and they had come up with these very well-described set of guidelines for designing Army medical centers, military health system medical centers that were evidence-based design. They have a whole, I forget what it's called, I think hospitals of the future or hospitals of something, something visionary like that. And all the hospitals that were being built in the last 10 years or 20 years were supposed to follow those guidelines. And I was part of this panel that was going and visiting all these hospitals, understanding their process to see if they had implemented it appropriately. So yes, it's been a huge part of their development. And one of the people who's a mentor and who I love her for many reasons, is Eileen Malone. She was she's now a retired Army nurse, and she's Chief Information Officer, and she was responsible for much of this work in sort of translating evidence-based design into a format that can be used by the military health system as part of their guidelines. So yeah, it was interesting work. But there's so much about the military. They're full of acronyms. It took me forever to learn them, learn how they work. But they have such unique challenges.
Good question. Awesome. Any others, Linda, that you saw that might relate?
No, we can resume after, and all the questions have been answered already. So I typed up all your answers, Dr. Joseph, so everybody has access to it too.
Thanks, Linda. That's very quick typing because I know I speak really fast. Thanks. All right, so I'm going to talk about this study, which has been like a passion project for the last 5-6 years. But we've done a couple of different projects, unrelated, but all in the same team on ambulatory surgery centers. So surgery centers, why did we look at them? Because there's been a real growth in outpatient surgeries, particularly because of the changes in technology, the changes in the way things are done. People can receive care, surgical care outside the hospital, and these are, you know, they can go home the same day, and this is a growing area. So we've done a couple of projects in this area, and typically the step when you're going in for a procedure, after you decide you're going to go in for that, you register, you go to the waiting area, and then you go into a preoperative area where the nurses will meet with you, the anesthesiologist, the surgeon, and make sure everything is okay. And then you go to the operating room, and then you go and recover in the post-operative room. And in case of an outpatient surgery, then you go home, often the same day. So I'm going to present two studies, one that has to do about the operating room, and the other one that is focused on the pre-op and the post-op areas of this experience. So this operating room project builds upon some work that was done at Clemson prior to my coming here. But this is typically, you know, when you look at glossy architecture magazines, this is what an operating room of the future might look like, or even of the present or whatever. But it's, you know, it's all nice and beautiful, the state-of-the-art technology and all of that. But unfortunately, this is how they actually look. I mean, this is work is done. That's how we imagine that, you know, it looks like that. They'll come in, they do the surgery, and everything is good. But these are really messy environments. You know, you have so many people. If it's an academic medical center, you can have 12 people in that room with all these instrument tables and all these wires, all the clutter. It's like, where's Waldo? Where's the patient in all of this, right? So it's a very complex environment. If you talk about complex settings, this is probably as complex as it gets. So our thought here was that we know a lot about how people need to be trained in these settings. There are a lot of challenges in operating rooms. There are, again, those patient safety issues are huge. There are risks of surgical site infections, there are risks of errors, and it isn't like these problems have been solved. And most of the solutions that we've heard about are training staff to do things better or getting in more technology. But the built environment, or the environments in which work is done, has remained the same for years and years. And there's very little research on the built environment. So our goal with this project was to do systems analysis of the operating room and then to come up with design solutions that can make a difference. So this was a 4-year grant that we were awarded in 2015. And we just wrapped it up last year in August. I mean, so we got a couple of years beyond 2018 to work through it. It's a multidisciplinary project. We have people who are from NUSC that we're working with, anesthesiologists, surgeons, nurses. At Clemson, we have industrial engineering faculty, architecture faculty, business faculty. As I mentioned, these problems are too complex for anyone, however specialized you are in healthcare design, for you to solve. So we learned very quickly how to talk to all these people, because they all have very different perspectives and different ways of addressing things. But I think it was a lot of fun. We learned a lot. And so we started with research, as I mentioned earlier. That's our DNA. We started with research, then we went into design, came up with solutions, and we tested it. I'll talk about that a little bit more. Don't look at this in any level of detail, but this is trying to tell you all the stuff we did in the first couple of years, because like all researchers, you can't come up with a solution until you know everything there is to know about it. So we did a literature review, we visited facilities, we did focus groups with clinicians, we videotaped a whole bunch of surgeries and we analyzed it to depth. We looked at the flow of people in the facility. We mapped out different procedures to see where people are, what equipment is needed, how do they place themselves. We looked at the bacterial load in the OR, we did simulation, we did a whole bunch of stuff, and we published a bunch of things, which I'm not talking about today, but all that research then led to this design project. So we learned what we did, and then the thought was, so what? Okay, so how can we come up with design solutions that we have to fix some of these problems? So these are our second year, they're all long since graduated and doing really well in architecture firms. And many of these students are now experts in operating room design, right? Some of them know more about ORs than many architects who practiced for years and years in healthcare architecture firms. So these guys were involved with us. We shared our research with them. And David Allison, who's the director of the graduate studies in architecture and health, led the semester-long design project. So the first thing that the students did in conjunction with the research team was to come up with a set of design guidelines. So yes, there's all this research, but how do we translate that into design? So we set up sort of these big goals. Our overall thing is to improve quality and safety. That's the whole goal of the learning lab. We came up with sort of design objectives. As I mentioned, our focus, our focus was on patient safety. But when you're designing a building, you can't narrowly focus on just one thing, right? So we had to think about how do you improve efficiency, how do you improve clinical outcomes and safety, how do you provide flexibility, how do you improve the experience, how do you optimize sustainable strategies. And then that was then broken up into actual design guidelines. So David does a really great job in thinking about how do you state them in a way that designers can do something with them. So these were the guidelines that the students were given. Plan the OR to optimize movement and flow, maximize visual awareness in the OR, minimize institutional clutter. So all of these were based on the evidence. All the literature review, all the evidence we did showed us that these things matter. So we gave these as the guidelines for the design. And then what we did was the students went through an iterative design process. So they came up, they were in groups and they combined them, they came up with concepts. The first thing we did was we put tape on the floor to figure out how large the operating room should be. Because that, again, no one knew how big it needs to be. So we brought a bunch of equipment. We had the doctors and the nurses come in and just kind of move things around to see approximately how much space do we need for all this stuff. And then in the next phase, they came up with some improved designs, and then we built the walls. And then the doctors were like, oh, this space feels very different with walls versus just the tape on the floor. And then we brought in some more equipment to be able to test different things. And finally, we built it out as a high fidelity simulation mock-up that looks very similar to an operating room. It has many of the equipment, it has the booms, and then we were able to do some testing. But I wanted to show you guys the video at this point to give you a sense of what this means. Let's see. And this is sort of our phase 2 mock-up, not the high fidelity one, because I think this is kind of fun. Oops, sorry. What did I do? Hold on. We will keep it like this. You guys can see it, right? Okay. So this is the cardboard mock-up, and one of the things we were trying to do is to test many different design ideas. So the students built this cardboard mock-up. They built it so that we could try different options, like move the door from one side to the other side and see what happens. So here they're doing simple simulations. This is actually an anesthesiologist. She's bringing in the patient bed and testing out if you come in through this door versus another entry point, how easy or not is it to move the bed and place it. Here they're testing out another thing where the patient is being induced in getting anesthesia outside the room and they're being brought in. But see, now they're trying a different door entry to see how well the flow will happen. So now we're trying out what happens when you bring all the stuff that they use in these surgeries, like the C-arm, which is just made out of cardboard. Or what happens when you bring in all these big instrument tables? Do we have enough space? So here again, they're not doing a full-fledged surgery, but they're just testing out various things. Just wanted to give you a flavor of what these simulations look like.
Before 10 p.m. and electrify your
Hold
metabolism
on.
by over 700
Maybe.
especially if you're over 40. I used to
Sorry about that. I
but
think.
then I saw the shocking proof for myself. A newly discovered bizarre tropical fat dissolving glue.
Sorry about that, guys. Okay. I should have just turned it off. So I just wanted to explain to you what we did really and what the steps are. And I think this might be really useful for most interior design projects. I think more and more architecture firms and interior design firms are building mock-ups of their designs so that the clients can begin to understand what that space feels like, what it looks like. That's been done for a while. But what typically happens is you bring in the users of the space and we ask them, what do you think works, what doesn't work? And they just kind of do a walkthrough and they give you some suggestions. But what we found is that only kind of touches the surface. What you can do is a simulation-based evaluation, which takes it to a completely different level. But what that means is that you have to work with your users and understand different scenarios. What are the ways in which they use that space? So in this case, we had those patients being brought in, being taken out, bringing in different equipment, and the team members around the bed. Because what we're trying to figure out is that during different use cases where the users have to interact with the physical environment, how does this work? So we're not just asking them, do you like where this thing is? We are asking them to do tasks, and then in the context of that, figure out what works or what doesn't work. So it's very important when you run the simulation to think about creating scenarios which will require your users to interact with the space in certain ways. So you saw them coming in, going out. We were trying to figure out what's the right door location. So we created scenarios that would require them to come in and out of the door and move the patient. And then you provide participant roles. And so usually, we had one of the clinicians be a simulation director. So he was telling them, come in and do so-and-so clinical thing. And then they would do that. And we actually had nurses and doctors who are doing their job, right? We're not asking them to be an actor. They're actually doing what they normally do, but we're asking them to do it in a different environment. And in that context, they're able to give us feedback on what works and what doesn't work. But as architects, you also have to think about, we have very little time with these people who are extremely busy. So how can you get them to test all the different ideas that you have? So that's why we came up with building these design alternatives, like how can you move a module from one side to the other side, do it quickly so that within 2 hours, we get all their feedback and then they can go back to their real jobs. And then, we have to be really quick in evaluating these alternatives and developing design recommendations. And one of the things that David Allison and I talk about a lot is that research is slow, it's plodding, it takes forever to publish it, but design has to work quickly. So if we are going to take forever to do our research, the project is completed by then. So we got to think about how quickly can you take that feedback and feed it back into the design process so that the students or your clients can do whatever, architects can do what they need to do. So after all that, this is kind of our design, and without going into a ton of detail, we looked at many different things. So, the door openings, we suggested that the doors be sliding doors versus opening doors, because there's a lot of problems with doors that bang into things, doors that impact the airflow in the OR. So we have sliding doors. We design the operating room so that it's kind of a flexible chassis where you can build in elements to it, right? If you could have an induction room, if that's the model that you want. If for orthopedics, we explored breakdown rooms, but that's a different thing altogether. One of the key things we found through all our simulations is this angled bed. In typical ORs, the bed is usually parallel to one of the walls, and that's what doctors are usually familiar with. But through our simulations, we found that if you have the bed kind of angled, it provides you a good way of kind of organizing the space. You can do right-sided and left-sided surgeries. It's easy to move the patient bed in and out. You get a nicely defined space with anesthesia providers in the corner of the room, because some of our research found that otherwise people were cutting through that space to get to various places. So we don't want that happening because it's very distracting. And then this lower quadrant of the room becomes the place where the circulating nurse, who does a lot of the movement in the room, they can be located there. And then, so the idea was to have clear circulation zone so people don't have to move around as much. We also suggested that the operating room have windows. It seems like that's common sense, but most operating rooms in the US don't have windows. So doctors and nurses spend like the whole day without having access to daylight, which is not a healthy condition for them. But it's hard sometimes because some kinds of surgeries require a completely dark room because they have to be able to access the screens, and there are issues of glare. So the challenge is how can you incorporate some of these ideas? We also had digital information displays on the wall so that information could be easily available to different team members that may be involved in the process. So this is just our final mock-up that was implemented. And this was actually built at our practicing, like our Clemson design studio in Charleston. So you can see there are students right outside in the studio. And so this stayed in place for quite a while. Unfortunately, it's not there anymore. I do have a video of what that looks like, but it's been taken down since then to make space for studios. And then what did we do with all this stuff? So we did the research, we came up with a prototype, and then what became very clear to us is that all this information that we have, we need to kind of bring it to a level that it might be useful to designers as well as clinicians. So we created this web-based safe OR design tool, and it's organized around these 14 design elements: doors, booms, windows, circulation zones, ancillary spaces. And each of these has different strategies associated with it. What would you do to implement it? Why should you do certain things? What are the outcomes that might come about from implementing it? Where's the evidence available to support it? And all of that. So it's simple. It's kind of organized like this. It's really easy to use. This is a website if anyone wants to use it. Or just to play around with it and look at how it works. ordesign.clemson.edu. We have some of these interactive images and things that you can kind of skim through, but all of these are organized in a way that it's meant to be useful for designers. So do take a look and let me know your feedback. We went through various rounds of testing to make it accessible, but we would love your feedback. And then eventually all of that, what was the point of it all? So MUSC was building 2 new surgery centers, and they worked with us. We were working with the clinicians, and they implemented it in their pediatric surgery center and then also the orthopedic surgery center. Since then, we've gone in and done post-occupancy evaluations, and it's been crazy because it's COVID and whatnot, but it seems to be working well from all we've learned, and we've published some of the work around it. I'm presenting that today. But what's been fun also that this project has attracted a bunch of other people who've been working on ORs, and we've helped them think through their design process. So this is a more easy tabletop thing we did using a magnetic board and little magnetic to scale people and equipment, and doing a little flow diagram of people coming in and out and the positioning of spaces, just to figure out how these different workflows would be accommodated and how these tasks could be accommodated. And these guys actually came to our mock-up. We did this tabletop thing, and then they actually simulated that in the OR that we just shared with you. And then we just found recently that they implemented our design pretty much in its entirety at the Emory Executive Park Musculoskeletal Institute. So they have the flooring design, the layout, the angle, even the ceiling is angled. So it's super exciting. We are hoping to go in maybe in 6 months or a year and see how their ORs are working. But it's really fun to see the work that you do as a researcher actually make its way into practice. And we do so much research, we love it, but does anyone else care? Yes, in this case we do. So it's been fun. And this is another small project. How are we on time before I get into this one?
We have about 30 minutes left.
Okay, good. This shouldn't take that long. And I just thought this would be fun for the students to look at because we use some fun tools in this one. So again, just showing you sort of this was happening in parallel to the OR project, and we say this is our baby project. That one was like an elephant. So this we had fun doing. We had fun with the other one too, but this was much more easy to put our hands around it. But we did some literature reviews, we did some observations in these surgery centers to understand nursing work in the pre-op and post-op spaces. Then we came up with some design ideas. We prototyped it as a virtual reality prototype, not physical mock-up, and then we tested it. So this is some of the early work we did around preoperative workspaces and how nurses work, and this was all published. And this kind of gave us the framework or the foundation for us to do the design work, which I think is probably more interesting for our students. So this is the research team that worked on it, many different people. Again, all of these faces are gone. They graduated and doing great things. But after we did that research piece of it, we then decided, okay, we have these ideas. How can we test them? How do we know these are going to work? So then we did a very short studio project, again, following a similar logic as the previous one. This was led by Byron Edwards, and I think this was like a 3-week project. But we gave them all the research, similar to what we did with the OR project. We kind of put it in a format that would make sense to them. And the idea was that they would come up with some design ideas for the pre-op room. And just to note, these students had worked the previous semester on an ambulatory surgery center project, and they had come up with basic room designs, just the walls and the space. They hadn't kind of done a layout design in that space. So they were given the challenge of coming up with a solution. And we gave them this design criteria and these guidelines. We said, the comfort is important based on what we've learned. It should accommodate furniture ergonomics, material selection, think about the ergonomics of the computer workstation. That was going to be really important. Visibility was very important in that pre-op area between the care provider and the patient, and between the care provider and the family members who are often in that room, and between the family member and the patient. Privacy is important in that space, both acoustical and visual privacy, flexibility to flex over time. How do you incorporate daylight and views? What kind of amenities can you provide while they're waiting in that room? Access to technology, positive distractions, and then just the functionality and adjacencies. And we told them that each of the rooms should have all of these design features, and they should support the workflow that needs to happen. And so, there were, I think, 9 students, and we organized them into groups of 3. And these were the rooms that they had developed as part of their project the previous semester. So then they came up with a design project, in the 3-week schedule, they came up with design solutions that incorporated all these features. And they had to explain to us how they met all these design criteria. So these are the 3 designs that they came up with. And these are the perspectives. And then we said, okay, how do we know which of these designs works? I mean, how do you judge, other than the prettiness of the drawings, how do you know which design is going to be more effective than the other? So we decided to do like a virtual reality experiment to test which option is better than the other. So what we did was a repeated measure study. We created these 3 design solutions using Unity, and we took it to the common study area within the School of Nursing, and we recruited a bunch of nursing faculty who are familiar with these kind of nursing tasks that we wanted. And essentially what we were trying to find out is, how are these 3 rooms going to support the nursing work that needs to happen? And so we had these nurses wear these headsets and go through each of these 3 environments and give us different kind of feedback. So basically we gave them a scenario similar to what we've done earlier. We would ask them to do different tasks like, okay, put an IV in a patient, find your gloves. And in Unity, you can make it interactive, where you can do all these things. And then we had these nurses, and many of them were like, we've never used this before. This is going to be crazy. But they had so much fun doing it. They even tell me now, oh, this was the best thing we ever did. Once you're willing to get over the whole fear of it. And after they went through each scenario, they gave us ratings. Our researcher asked questions to rate the work performance within each prototype, and then they gave us interviews. We did interviews with them to get a little bit deeper perspective on what worked and what didn't work. So we had these kind of data. In addition, the VR platform itself captures different data like angular motion, and the hip trackers collect data on their movement in that space. So you don't have to read this in a whole lot of detail, but basically what we found was that room 2, which is the one with the funky angle, it did the best in terms of physical access to patient care supplies, in terms of physical access to all sides of the patient. So they're able to access all sides of the patient, unobstructed movement during patient care activities. And the nurses also felt that room 2 had enough space to accommodate flow of additional equipment. So it seemed to do well on all the survey data. And then we looked at the data from the headsets, and what we found is the proportion of time, that's the metric that we came up with based on what we were getting from the headsets. In patient room number 2, the patient and the care partner were visible to the care provider during more time than in the other 2 rooms. And okay, this is with the patient. The patient was visible, the care partner was a lot more visible in the second scenario. And in terms of the distance traveled while completing tasks, they travel the least distance room to. So it was more efficient in many ways. When we asked them what are the elements that they really liked about the different rooms, they liked having enough space around the patient bed, they talked about the size and location of the care partner zone, having enough space to do different things. Visibility was really important, having multiple viewing options, that not only did you have to see the patients and the family members, but the patient should be able to see the TV, the view to the outside, the ceiling art, and so on. They liked the co-location of the shops and the waste disposal and how things were convenient to each other when they were trying to do the tasks. They liked the light wood grain and some of the fabrics and motifs. They liked the rubber floor. There were various things that they liked. But anyway, so then we looked at that and said, okay, this is the original design. And our students came up with the graphics to explain why different things work. So in this particular design, they have the window on one side, the bed is at an angle. They actually came up with this boom solution where all the patient records as well as the vitals were always can be moved around. So it gave maximum flexibility for the care provider to be on different sides of the patient and to do the different tasks that they needed. And then there was enough space for the family member, but they could also be visible to each other. So these are some of the different aspects of it, and easy to bring the patient in and out, enough space around the bed, and so on. In terms of viewing options, as you can see in this particular option, that was maximized because they were all able to view each other, view the TV screen, view the outside, and all of that. These are some of the other design ideas, again, related to that, of the features that were incorporated that the nurses particularly liked. So, but the question for us was like, okay, things are working here, but it's a really funky design. I mean, you're not going to be able to implement that in any hospital project, just from a constructability standpoint. And there were some problems with the lack of space near the care partner area. So our challenge, I mean, we didn't design it as a full-fledged project, but this is just not the design students, but the research students afterwards said, okay, if this is working, there are certain aspects of it that work. How can you make it into a more practical and maybe traditional solution? So this is just an option that we came up with where, you could still have the view to the outside from the bed. You had space for the family member, you had the ease of movement and access to the TV and such. This area is wasted space, and clearly we need to do some more design work to figure out how we could make it more efficient. But this was one way of figuring out how it's going to work. And then we just did some quick diagrammatic simulations to see if all of these elements that we want, access and with visibility, how are they going to work in this space? And we also converted this into like a virtual reality and took it back into the nursing school. And we didn't do a full-fledged study, but we did have them experience it, and they use the same finishes and everything. And in some cases, they couldn't make out the difference. But it seemed to be something that seemed acceptable to the nurses, but we probably should do more research on that. But this is just some of the testing and to see how things work. But I just wanted to kind of wrap it up with this, that we have begun to experiment with the use of virtual reality, both as a design tool and a research tool. And I'm sure we're not the only ones doing that. A lot of people are doing that out there. But when you're trying to use virtual reality for research, specifically, some of the things it's not the best solution for everything, but it is a nice alternative to doing experimental studies, because you never find 3 different rooms that have all of these characteristics. You can't do those kind of real life studies. So you might be able to do it in virtual reality. And with COVID, it gives you another sort of way of getting data from your participants without having to be in that space with them, and gives you some flexibility with research. But the ability to use it depends on how much interaction you need. The thing with healthcare is that it's a team sport, and there are patients, there are multiple clinicians, there are family members, and to know if something works, you possibly want to get all of them in the room and all of them interacting as they would in a real space, which you can do well in a physical mock-up, but it's a little bit harder to do in a virtual reality kind of a thing. So I think that'll improve as these VR platforms improve and they become cheaper to build, and you can have multiple users. Some of that is happening already, but you also need it to be highly realistic. And you have to make sure that the VR doesn't make people dizzy and nauseous, which can also be a problem. So there are many aspects of it that should be considered. And we have a paper that we wrote about using virtual reality. It's published in her journal, in case anyone's interested. So just wrapping it all up, the core of the work is that humans are the center of everything. Any design work you do, research, the goal should be on improving the work and the experience for humans, whether it be patients, whether it be staff. You have to think about how the system impacts what they're doing. And when the system demands significant physical and cognitive adaptations, that is, you can't do your work seamlessly in that environment, and the environment is constantly impinging on you and causing more stress, then that means there's something wrong with that system. And that's why we need to make it so that they don't even realize that there's a physical environment. They just do it. They're not making those adaptations. So a well-designed and therapeutic environment should be intuitive, should be flexible, and supportive to all users and at all times. And thank you all so much for being so attentive and listening and asking those great questions.
Thank you. We have more questions too. So we'll get to what we can in the last 15 minutes. So back to your last study you were just talking about, or the last project, how much time did each participant spend in the VR environment?
I think not in each environment, probably like a couple of minutes, because they just had to be, no, not a couple of minutes, sorry, it's probably like 5 to 10 minutes, because we had them do different tasks, but we didn't restrict the time in it. If they wanted to spend more time and explore, they could, but for the most part, it was scripted. They had certain tasks to do, and they kept it on for the entire time. So altogether, they would have spent, say, 20 minutes or so at most. That's the average, because we felt after that it would get too tiring.
And then going back to your OR, to the OR room, do you foresee these OR room solutions being implemented in more hospitals in the future?
I think so. I mean, I like any building project, every project is unique and they have their own constraints. But what we believe is we've come up with some standard principles that can be applied in different projects. So rather than saying, let's make our OR exactly the same as what they did, our hope is that they consider these different elements and these different guiding principles and the desired outcomes, and they use that to base their designs. But we've had various people come through our mock-ups and they've tested it, and they've found that some of our principles and even some of the design ideas work. But there will be variations from design to design. So some people may not feel comfortable with the angled bed. It seems kind of hard for them, I think, culturally to adapt to it, but others have. But I think the principles around laying out the room in logical ways, putting storage next to where people are working, all of those concepts work and are transferable. I think it's already being used in many hospital projects.
And then on that as well, did you evaluate the HVAC system zones in relationship to the operating zone?
It's a great question. The students are amazing. So the HVAC we could not test because our mock-up was like an open mock-up, and we were able to implement the booms in the final version of the design. So the boom location also needed more testing. So we could not really test that. As you can see, in the Emory project, they changed the orientation of the HVAC as well, so that it's kind of angled over the bed. That needs more work. So we haven't totally figured that out, and we don't know what's the best solution for the HVAC system. The one thing we have found is that even though we might propose a particular bed angle, surgeons, clinicians often change the orientation of the bed during the surgery or between surgeries. So there is no one set bed angle that's used anyway. So even if you have a particular HVAC solution, the truth is that the bed changes frequently. So yeah, I think we need to do more work on that.
Awesome. So we had numerous questions related to kind of the trends that you see in healthcare. So where do you see the healthcare trends going in the next 10 years? What are, if any, some of your fears in design with all of the new technology and advancements?
Great questions, both of them. I think there are multiple within that. In terms of trends, I think what we've been talking about for a long time, and it's happening more and more, is the move to the home. We've been talking about that for a long time, that healthcare is not going to be in hospitals. Hospitals are going to get smaller, and more is going to be outpatient. We're seeing that anyway. So outpatient procedures are becoming more and more common, but more care will be at home. So many of the things that you do on a regular basis, come in for a checkup or to get monitored for something, that can probably happen with remote monitoring. Telemedicine is obviously a big thing now, so you don't even need to go to your doctor's offices. That was on the fringe, and one of those things that, yeah, maybe we'll do it 2 years ago, but now it's pretty common. All of those things are definitely going to impact how we design our facilities. I've been in various panels where doctors feel like, no, the rooms are not going away. The exam rooms in the emergency department, in clinics, they're still going to be there. Because if you have to not just think about the patients and their care being at home, but for the clinicians, it's hard to be in their homes and do telemedicine all day long. There is a lot that they learn from each other and being with each other. So you kind of need to think about clinician burnout and clinician ability to provide the best care for telemedicine as well. So I think those are all the things that are happening. I think staff burnout is a big issue. The numbers of people leaving the profession or just getting burnt out is high. So I feel like there will be more and more care given in healthcare design projects on actually investing something for the staff, not as an afterthought and not in the basement and not in the corner where no one ever goes to. So I think that's another positive trend that we will see for sure.
And this question really closely aligns with that, but how has the trend of technology increased since you started your research into the healthcare and evidence-based design? Do you feel like it takes away from the interpersonal experience in healthcare? And third question, have you seen any unconventional or out-of-the-box applications?
Oh, so much. Okay. Yes, technology. I think technology has always been a big part of healthcare. I think since we started, the big thing that has become more common is electronic health records. I look at the IOM reports and all of that. 20 years ago, they talked a lot about how information was not being shared. There was no interoperability. So that has changed quite a bit. Most hospitals and healthcare systems now have electronic health records and they're not doing stuff on paper. So that is something that's become common, and that has helped with communication and transfer of information in a good way. There's still a lot of technology and equipment. Everyone loves their toys. And it has helped in providing better care. The kind of things you can do in surgery, the fact that things can be outpatient, is because the technology has improved. And that's going to continue improving. Well, I've forgotten the other two questions.
Last was, well, do you feel like it takes away from the interpersonal experience in healthcare? And then any unconventional or out-of-the-box applications that you've seen?
I do think, there's always this challenge between the human touch and the high tech, right? So with this particular project that we did, the virtual reality thing, we were thinking about how do we make this connected and human by providing visibility, allowing communication. Because the one thing we had observed is often the technology becomes a barrier. The nurse is often hidden behind the workstation and they're so busy documenting that they don't connect. So that was actually something we wanted to address in this particular project by having the students think about not just coming up with their technology solution, which is a cool workstation, but how does it fit into that space? How does it support that human interaction, which is at the core of healthcare, really, really important. So I think that's always going to be a challenge as we get more and more high tech and we have AI, we don't even have doctors anymore. We have people who will talk to us and tell us all our problems and tell us the solutions. Where does the human touch come into it? And I think that's always going to be important. But the other question you asked was about the interesting applications of it. One of the projects that I've been involved with, which I've really enjoyed, is integration of telemedicine for stroke care in an ambulance. So that's not a typical healthcare environment, but MUSC has this great telemedicine program, and they have been trying to provide stroke care to patients throughout South Carolina, which is pretty rural. And for stroke care, it's really critical that patients be seen as quickly as possible, because it's a time window makes all the difference. So if patients cross a certain window, their chances of survival and improve and diagnosis and everything reduce. So they have implemented these telemedicine systems where, while in the hospital, the EMT can talk to the neurologist, they can talk to the nurse, and they can figure out solutions. So one of the things we saw is that that's really effective. But we try to figure out how could you implement that in the ambulance to support that human touch interaction, because what we found was the clinician could possibly see the patient because of where the video was located, but the patient couldn't see the doctor. So they were kind of talking randomly, and that impacted their communication. But we are seeing those kind of implementations which really help in improving patient care and improving equity of care and access to care for patients who are far away. I was talking to someone again at MUSC, and they're thinking about how they can integrate MRIs in the ambulance. So things are changing quickly. People are testing out these ideas. They're trying to see how we can push the boundaries. Things work really slowly in healthcare, but there's hope. I mean, there's some really interesting things happening out there.
Wonderful. So I feel like you're answering these questions rapid fire because we had a lot. So we'll just maybe hit 2 more.
I'm glad there are questions. There's nothing worse than a presentation where no one asks questions. So I'm happy.
So we had a question that just came in. Is the research simulation conducted the same way for every project, or are there ways that it improves and changes each time based on different human reactions and being in such a dynamic environment?
Yes, that's, again, I mean, I think your students are amazing. So they're great questions. But yes, the simulation changes every time depending on the type of questions you're asking. I think the simulations we do are different from your clinical simulations, which are often done to train clinicians, right? They do the same thing multiple times and they improve their skills for training. But in the case of these kind of environmental simulations, we are trying to answer certain questions. So the simulations are designed to test interactions with the physical environment. And while it may not change between participants as much, it'll change on the context. So I would do a different simulation in an intensive care unit versus an OR, or I would do a different simulation depending on the fidelity of my mock-up. So if I have a tape on the floor mock-up, the best I can do is just blocking spaces and seeing is there enough space. But if I have a cardboard mock-up, I have a bit more sense of space and volume and objects, and I can move things around. But the higher the fidelity of the mock-up itself, like I have all the equipment I need, I have gases, maybe if not, at least the lighting systems, the HVAC, then I can actually simulate a full, a proper surgery. So it's not so much that it varies between people, but it can vary, the type of simulation and the kind of things you can ask, the questions you can ask will vary depending on the fidelity of the simulation. And because one of the things we actually found in our post-occupancy evaluation was that there were some problems in the new ORs, but there were things like the location of the phone, the position of the light switches, because we didn't test those things because we weren't testing light switching and where is the button placed where that allows the door to open. It was too far away. So those things, the more detailed your mock-up is and the more detailed your scenarios are, like if we had created scenarios where we had them simulate a phone call and they had to go somewhere, then maybe we would have a better sense of where that should have been placed, or if they had to press the button to open the door. We didn't even, we didn't have those scenarios. So the more detailed your scenarios, the more detailed your feedback can be.
All right, let's close it out with what advice do you have for an undergraduate looking to enter healthcare design?
I would, that's a great question again. So I think if you're an undergrad, I think be curious, just want to find out everything you can. That's what keeps me going. And that's what I think for your long-term careers, whether it's healthcare or anything else, look into things that are out there. Reach out to folks. Sarah's a great resource. She's from your program. She can help you guide the way. And the one thing I didn't mention was we have different kinds of programs. Healthcare, I think the architecture and health program at Clemson is amazing. So if you want to get into healthcare, highly recommend getting a little, there are other programs as well out there that can give you the structure and the guidance and help you kind of make your way into healthcare. But if that is not the case, there are lots of resources out there. The Center for Health Design is a great resource. They have lots of free tools, lots of papers. I would recommend you read that. If you're an undergraduate and you have the opportunity to do a thesis or a design project that goes into healthcare, you can begin to explore some of these things. We have a program in an MS to PhD program, which is basically what Sarah did. She joined as an MS student and then continued on to do PhD. But that's another great option. Reach out to me if you are excited about healthcare. I've been here for a long time and I'm happy to guide you and be a resource to you. But again, just be curious, want to learn, and the world is all yours. It's kind of a really big thing, but again, I'm here as a resource if you want to reach out to me.
Thank you. I apologize to everyone's questions that we didn't get to, but we had a lot of really good ones. So thank you so much, Dr. Joseph. We appreciate your talk so much. It was very beneficial. And we appreciate you visiting School of Planning, Design, and Construction in the Interior Design Department.
Thank you so much. I enjoyed it so much. And thank you for your wonderful questions. It makes me happy.
I just want to make a public announcement that Dr. Joseph is the chair of EDRA 53 conference that is being hosted by Clemson University in June 2022. Registration is open. We have a discounted rates for Michigan State University. If you have any question about registration, please let me know. The theme of the conference is Health in All Design. So if you're interested in pursuing this, please get in touch with me and I'll guide you through the process.
Thank you, Linda, for that. I forgot to add that slide. I appreciate it. No, we would love to see you guys in Greenville and in Clemson. So that's a great way to do a campus visit if you're interested. But if not, I think this conference will give you lots. So enjoy. All right.
Thank you. Thank you, Dr.
Thank you so much.
Bye.
Bye.
Bye.